welcome again, especially for those who have watched or seen my series on cardiovascular system, my presentation. There are a few facts that I believe they are useful for you in the medical field, nursing, or any other related area, because they're just useful, and I'm going to share with you guys. I hope you take advantage of some of the issues that we're going to share with you. One of them is regarding the pericardium. It may be kind of confusing when you look at the heart, only histology. You see an area that's endothelial here and mesothelial here, and both are flat. And this corresponds to the epicardium or visceral pericardium. I just like to remind you that the heart is wrapped by the visceral pericardium, which folds back itself at the root of the great vessels, goes back again, and forms a sac containing small amount of fluid that leaves the heart freely to move and do its job for as long as we live. And that is pretty much the concept of pericardium. Similar foldings are happening in the lung and in the peritoneum, and the cells in question, mesothelial cells, are pretty much the same. Now, regarding the lymphatics, I'll just remind you guys that the histology is almost very, very similar to that of a vein, perhaps a little bit thinner. They do have also valves, as do the veins, but they do not contain blood, and that is what makes it easier to recognize in the in the histologic slides, right? It's important to remember that the lymph nodes appear later in the course of the lymphatic vessels, especially in areas like the inguinal area, the axilla, etc., the neck, and certain more areas that are quite classic. If there is damage to the lymph node, either by surgery or by some other way, we have a situation in which we already called its accumulation of interstitial type fluid called lymphedema. And that, in a case, for example, of breast cancer, it may be very, very bothersome, difficult to even treat and to deal with. So lymphedema is important. The next system, regarding the portal system. Regarding the portal system, we know that it's very special. You know that the abdominal organs have a special kind of circulation that needs to go back through the liver, through the suprahepatic veins, to the inferior vena cava, to the right side of the heart. In that, if we have a cirrhotic liver, the flow of blood becomes sluggish and finally almost impossible. And the blood tends to be stagnant and difficult and impossible to go anywhere, and looks for places to try to go back to the general circulation. And one of the most common places is the lower third of the esophagus, forming esophageal varices. So a patient with cirrhosis will have esophageal varices because of the fact that the blood is going to try to go back to the general circulation. Okay, I'm going to just go briefly cover the issue of septal defects. The heart is a complicated organ, as the body is, and many cardiac congenital anomalies are present, but I'm going to just mention quickly the septal defects, the atrial septal defect and ventricular septal defect. In general, the pressures on the left side of the heart are higher than that on the left. Therefore, we're going to have a shunt that is going to go from left to right. In this case, the shunt is going to be really very impressive because the pressure of the left ventricle is much higher during systole and produces a bruit and a murmur that you can actually palpate and easily listen with your stethoscope, which produces a lot of extra work to the right side of the heart. Now, the atrial septal defects, since the pressures they're not too different. There is a shunt from left to right, but it's very minimal and very subtle. So the patient may reach adulthood and not know that they had a atrial septal defect, unless it's found accidentally. Let's see more atrial septal defects. Regarding the valves of the veins and the valves of the heart, which are foldings of the intima, essentially, as we mentioned before, the valves of the veins, especially those of the leg, can become insufficient. Those persons that are standing for a long time or have a little bit extra overweight, they tend to accumulate too much hydrostatic pressure in the veins, and they dilate in the vessel, and the veins are insufficient. So they have engorged veins in the legs, which are varicose veins, and that's something to remember. Regarding the valves of the heart, the AV, the mitral, tricuspid, aortic, and pulmonary valves, there are two main issues with them. It could be insufficiency, it could be stenosis. I'm going to just mention, for example, the case of the aortic insufficiency, which is relatively more common, in which there is a certain amount of blood that goes out and then goes back to the heart because there's not a good semilunar aortic valve that is going to block the blood from coming back. So the heart has to work much more because it has extra amount of blood. And eventually it can go into insufficiency. I'll mention just briefly also the stenosis, with the opposite effect, in which the valve usually becomes calcified, stenotic, small, and the heart has to push with all its strength to try to force the blood through a smaller orifice. At the beginning, the left ventricle becomes thicker, and finally it becomes just dilated or insufficient. So it's very important to change the valves, and valves can be changed differently, including not even the need to open the chest. That's the way things are right now. Regarding the final point, which is the atherosclerosis, you probably have an idea already that it's actually not very important, I don't really have to mention much, is the fact, for example, in the myointimal cells of the aorta and other arteries, they accumulate lipid fat from elevated cholesterol or triglycerides, and those cells enlarge and eventually calcify, and you hear large plaques of atherosclerotic plaques in the intima of the aorta, and also the coronary arteries and all the other arteries, such as the ones in the pelvis or the legs, for example. And that is a problem. That is a significant problem because, for example, there may be a formation of an aneurysm. The abdominal aorta becomes dilated because of the lack of, support to the calcification, fibrosis, etc. And that abdominal aneurysm may eventually even rupture and be very difficult to treat. Regarding the atherosclerosis of the coronary arteries, it's something that's well known for you. The coronary arteries will also become thickened by the atherosclerotic plaques, and eventually, that if there is no necrosis, the patient may do some exercise and feel some pain in the heart. But if there is a rupture of the plaque or there's a thrombosis, we will have the possibility of a myocardial infarction because there are a portion of the heart that will not receive enough blood. Then we have an issue. I'll mention very briefly a couple of facts regarding pressure. We have the systolic and diastolic pressure, and you have to, of course, that the systolic pressure depends on the force of the heart to pump the blood, and then that blood slowly is being distributed to the different arteries. Now the diastolic pressure is secondary to the stricture of the smaller arteries that are many throughout the body. So if for some reason there is an increased stricture of those small arteries, the patient starts experiencing hypertension, actually the diastolic pressure becomes higher and higher, and it is a problem that has to be treated. And also, in the case of the aorta, when the aorta becomes rigid and too calcified, the systolic pressure will increase because of the fact that the aorta doesn't actually move, that it's not elastic enough to receive the blood from the heart. And we have an adult patient such as me that may have a systolic pressure that is higher, but the diastolic is a problem related to the smaller arteries. I hope these facts are useful to you in your lives, in your medical practice, or wherever you are, and we'll see you next time. Bye bye.